Hi everyone, thank you so much for joining. Apologies for the late start, I've had some technical issues, but hopefully you can all see the presentation. I'm going to be talking to you today about Paediatric ENT Emergencies. My name's Louise, I'm one of the ENT registrars at QA Hospital in Portsmouth, and I hope that by the end of this short presentation you'll feel a bit more confident in dealing with our paediatric population and some of the things that we see them for in ENT. So, a quick overview on what I hope to talk about today. Firstly, foreign bodies, and they can end up in the nose, the ear, airway, and esophagus. I'm going to talk to you about post-tonsillectomy bleeds, noisy breathing and stridor, and I'm also going to touch on mastoiditis and periorbital cellulitis. I know they've been covered in previous talks, but they do predominantly affect children, so I thought it was important to include that in this presentation too. So firstly, foreign bodies. Nasal foreign bodies are not uncommon. They tend to occur in kids usually between the ages of 2 and 5. There's usually a pretty good history from their carer or parent. It's often witnessed or suspected. And when the child comes to see you, they're normally quite well. They're normally asymptomatic, running around, showing no signs of distress really. The issue with them is that they do carry an aspiration risk. And although it's rare, there is the theoretical possibility that they could sniff the foreign body into the nose, down into the airway, and for that to cause airway compromise. So we do tend to take it a bit more seriously than other foreign bodies, for example, in the ear. Always remember that unilateral nasal discharge in a child is a foreign body until proven otherwise. So although they're often witnessed, they are sometimes unnoticed, and kids can put these things up their nose, not tell anyone, and it's not until weeks, sometimes months later, that they present with a foul-smelling discharge from one side only and are otherwise well, in which case they need to be investigated for a foreign body in the nose on that side. So before they get to see you in ENT, they will often have been seen by someone prior to that, Paediatric A&E or a community treatment centre, and they will often have tried some more straightforward procedures or manoeuvres to try and get the foreign body out. Something that we often recommend to parents and carers is something called a parent's kiss or a mother's kiss, as it's sometimes called. And what that is you ask the carer to occlude the side of the nose that doesn't have the foreign body in, and get them to blow through the mouth in a short, sharp, pressured way, much like giving mouth-to-mouth resuscitation, in the hope that that pressure will push the foreign body out of the nose. Sometimes it works, but obviously the patients that we see are the ones where this unfortunately hasn't worked. So definitely something worth trying and advising over the phone if you're dealing with someone who isn't necessarily experienced in treating kids with foreign bodies in the nose. I've added paediatric otrivine drops there just because sometimes you'll see kids who've been referred and whose parents or carers will say, give you a really good history for them having a foreign body in the nose. They've seen them put them up the nose, for example, and at some point have seen the foreign body in the child's nose themselves. And you'll look and you cannot find it. The nasal cavity in kids is quite small, so you should really be able to see back to the postnasal space when you have a look inside. And if you can't find anything, that can be quite disconcerting. So what I often do is pop a few drops of paediatric otrivine into the nasal cavity, and that just takes down some of the swelling in the anterior portion of the nose, and that can make a foreign body more obvious or reassure you more that there's definitely nothing in the nose. Sometimes the kid will have sniffed and swallowed the foreign body, or it's fallen out without them realising. So trust your clinical judgment. If you can't see anything in the nose, reassure the parents and tell them to come back if they have any signs or symptoms of unilateral nasal discharge further down the line. So if you've got this foreign body in the nose, how are you going to get it out? We always say you have one attempt at removal, because kids will rarely let you have a second go. And so it's really important that you get the setup in your room just as you would like. So I usually swaddle the child, which is obviously easier the smaller they are. But even the larger kids, getting them in a blanket so that they can't reach their hands up to their nose is a good idea. Always seek the help of a paediatric nurse or a play therapist, because they have some really good tricks up their sleeve to keep the kids distracted. And I cannot stress the importance of a good headlight in this situation. It does make the difference between seeing the foreign body and, poking around in the dark, essentially. So make sure you get yourself a good headlight. Position yourself so that you have the child facing you, sitting on the lap of the parent or a nurse or another member of staff if the carer or parent doesn't feel up to it, with their knees in between the parent's knees, facing you. And I normally try and just explain to the parent, out of earshot of the child, exactly what I plan to do. And I usually say it'll take a few seconds and it may avoid the need for a general anaesthetic. I'm yet to meet a parent or a carer who isn't keen to give it a go, in the treatment room or in A&E, with the child awake, even though they know it will be a bit uncomfortable. But I think knowing that is half the battle. So in terms of how you physically go about removing the foreign body, the picture on the right shows a wax hook, essentially, which has a right-angled bend on the end that you use to get behind the object and to bring it forward along the floor of the nose. I actually prefer using a Jobson horn probe, which is the left picture underneath the writing, and I make a 45-degree bend at the end of that, the curette end, so the end with the ring on it, just to make it a bit more sturdy in terms of getting behind the object and pulling it forward. Thankfully, with nasal foreign bodies, kids do tend to help you out, because when they're presented with someone in front of them with a headlight who's going to try and put something in their nose, they tend to firstly close their eyes, and secondly put their head back onto the person behind them, which, if you're behind the object at that time, works in your favour, because they'll move their head back, you'll move the object forward and bring it out through the front of the nose. So another common place for kids to put things is in the ear. This requires a much less urgent removal, unless it's anything corrosive, such as a battery. And I will come on to batteries a bit later on in the talk. So for example, if you take a call from a treatment centre in the evening, it's completely reasonable to say the child can come back the next day, or even the day after, if the treatment room clinic is looking full or there are other reasons why. So you don't necessarily need to see them that night. In terms of how you physically get the object out, suction can be useful. If you've got, for example, they sometimes like to put little polystyrene balls in their ears. That can be useful for those. And crocodile forceps can be useful for objects with an edge. So a flat piece of cardboard, for example, is often easy to grab with a pair of crocodile forceps. But really, kids like to put things that are much more annoying in their ears. Round objects, usually with very little grip. So things like beads and things like that, which crocodile forceps end up just pushing them further in the ear, and suction isn't strong enough to pull them out. So a wax hook, which, going back to the previous slide, is what's in the nose in this scenario, and it's used in exactly the same way. So you need to get behind the object and pull it forward The only difference in the ear is that you're using a microscope instead of a headlight, and it's slightly more difficult to get them into a good position because you can't really swaddle them on the couch. And so you need a kind of a more semi-cooperative child in that case. Obviously, if you're unsuccessful, then you can let the child go home and bring them back for it to be removed under general anaesthetic. One thing that I've learned the hard way is to always check the other ear in these cases, because kids won't always tell you when they've put something on the other side. So another common, well, less common but important place for a foreign body is in the airway. And these can end up in the larynx, the trachea, or the bronchus. And obviously, as you'd expect, the laryngeal foreign bodies will be much more of a clinical urgency than a bronchial foreign body. And actually, children are amazing at compensating for a partial bronchial obstruction. So it's really, really important to have a clinical suspicion of a bronchial foreign body. So if you hear a history that sounds as though a child has choked, or there's been an episode of coughing followed by going slightly blue, but is now absolutely fine, it's really important to take that seriously. And these are the kids that are quite difficult to kind of work out sometimes. But if you ever hear a history that sounds anything like that, it's always really important to talk to your seniors. And as a disclaimer, as an ENT SHO, you'll never be expected to be managing, bronchial foreign body issues in kids. But you may take a phone call about it, and you may need to relay some information. So if there's anything that sounds like a child has choked but is now fine, more often than not, we're kind of obliged to take them to theatre and have a really good look around. And I've had it before where a child has been in the playroom absolutely well after having a choking episode, and we've taken them to theatre and found a piece of confetti in their upper airway. So they are really, really good at compensating, and a really good history and clinical suspicion is really important. So esophageal foreign bodies is another place that we need to think about. And again, the kids who come into hospital with an esophageal foreign body that's in the upper esophagus, which is obviously more of our territory in ENT, are often asymptomatic. So they might have dysphagia, they might be drooling, but they equally might just be sitting quite quietly in A&E, seemingly unaffected with normal observations. So if there is evidence of history from the parent, then always really important to take it seriously and investigate. Now, the foreign body in this X-ray is a button battery, which has the telltale sign of this double ring around the edge of it. And they are really, really, really dangerous, basically. So it's really important to treat these children with the utmost clinical urgency, and these button batteries need to be removed within 2 hours. So the guidelines say that the batteries need to be removed as soon as possible. And actually, I had a case a few months ago where a child had swallowed a button battery, and a paper was kind of brought to my attention at that time, which is fairly new, that suggests that eating honey while you're waiting to get them to theatre is potentially protective. So it's supposed to put a protective coat on top of the battery to prevent some of the toxic effects. And it's really tricky because these little batteries are so small. They're a perfect little shape. They're shiny. They're found in remote controls for your TV. They're found in watches. And they cause damage in two main ways. Firstly, through a kind of pressure necrosis in the esophagus. And secondly, because they emit an alkaline toxic liquid that just erodes essentially the mucosa of the esophagus. So it's really, really, really important that they're taken out as soon as possible. I would almost even say, if you get a call about a button battery, or even see an X-ray like that, that you call the registrar before seeing the patient. And I'm sure the registrar will probably call the consultant without seeing the patient. It's one of those really tricky, time-critical things in ENT. Yeah, that's all I had to say on button batteries, and it goes for anywhere in the upper area digestive tract. Really, it's not just esophageal. Button batteries in the nose or the ear are removed on an urgent basis. So noisy breathing is again something that causes lots of ENT doctors lots of stress. So not just SHOs, but registrars and consultants. And as an SHO, you'll never be expected to manage a paediatric airway emergency on your own. But as I said before, it's really important, if you do get the call, to know what you're asking, so that you can help to just relay your information and start to maybe triage how important or how worried you are about this child. So when you're taking the history, which will usually come from the paediatric team, because they see lots of breathing difficulties in children, you want to know about the onset of the noisy breathing, or the stridor, or the stertor, or whatever they're calling about, how long it's lasted for, whether there's a history of any upper respiratory tract infection, or cough. As we know, croup is really, really common in children. And again, as I said before, with the always bearing in mind the clinical suspicion of choking, is there any history of choking, or episodes that might lead you to believe that something has happened untoward with that respect. Other factors that you want to know about: do they have any problems with feeding? Are they gaining weight appropriately? Are they meeting all their milestones? And then what's of utmost importance is knowing their birth history, whether they were preterm, and whether they've ever been intubated or had surgery. And that's again would completely change our recognition of how seriously we're taking this presentation. Vaccination history, as you'd include for all of your children. And if you did ask about cutaneous hemangiomas, you'd be earning extra points, and that's purely because cutaneous hemangiomas are associated with subglottic hemangiomas. And so if you are thinking that you could be dealing with subglottic stenosis, it's good to know if there are any history of any birthmarks or hemangiomas on the skin. Of course, that is, you'd look really good if you went to your registrar consultant with that information. So just a summary of the level of obstruction based on the noise that we hear. So stertor is, it's often difficult to tell between the different noises, particularly in the young babies, because they often make lots of little noises while they're sleeping, in particular. But stertor typically means that there is an obstruction in the upper airway, so in the nose, the back of the nose, the oropharynx. If you have an inspiratory sound, so an inspiratory stridor, that normally means the obstruction is at the level of the supraglottis. So that would include your classical epiglottitis, which we don't really see anymore, supraglottitis, things like that. In adults, your kind of laryngeal cancers, supraglottic, hypopharyngeal cancers will all give you an inspiratory stridor. The biphasic sound, so inspiratory and expiratory sounds, tends to mean that the obstruction is at the level of the glottis, so the level of the vocal cords, or just below in the subglottis. And of course, expiratory sounds tend to mean lower airway, so trachea and bronchi. In terms of management, as I said before, gathering all the information is of absolute paramount importance. And, lots of people, senior ENT surgeons, would say that, managing a paediatric emergency the airway is more about making difficult decisions based on the information that you have at the time than anything technical or surgical or procedural. So information is really, really important. Know where the paediatric airway trolley is. Now, I work in Portsmouth, and in Portsmouth and I think Southampton, we have a MAST trolley, which stands for Making the Airway Safe Team, and we keep that outside theatres on E level outside Theatre 6, and it's multicoloured like this picture, and it's just got all the kit that you could ever need if you were to deal with a paediatric airway emergency. So if you are working in QA or Southampton, it's really good to find out where the trolley is, and if you're not, there'll probably be an equivalent in whatever hospital you're working in. Call for senior help, which you probably already have done, and the paediatric team may have as well. And in the meantime, waft some high flow oxygen near the child without distressing them, and you can give some nebulized adrenaline with or without budesonide, and consider giving some steroids, either intravenously or orally. Obviously, difficult decisions have to be made in terms of, do we distress the child by getting IV access if we don't already? And so that's why we might go towards an oral steroid alternative rather than an IV. But those are all kind of decisions that are made kind of multidisciplinary, with usually paediatric nurses and paediatric consultants and anaesthetists all together. So there are a few things that we can do in order to prepare the team and make sure equipment is available, and that will be really, really useful in that scenario. So the next slightly stressful thing when it comes to paediatric ENT is post-tonsillectomy bleeds. Now, we break down post-tonsillectomy bleeds into primary and secondary. The primary bleed takes place within the first day or so of having the operation, which is uncommon. It's far more common to have a secondary bleed, and that can happen anywhere up to 2 weeks post-op. Commonly day 7 or anywhere between days 5 and 9. And using the conventional techniques of tonsillectomy, it can happen anywhere between 4 and 8%. So it's not a really rare complication. And I'm sure in some of the literature, it's anywhere up to 10%. So we're talking between 1 in 10 and 1 in 20 patients who have a tonsillectomy, which is, of course, a really, really, really common procedure that we do. They will have some form of post-tonsillectomy bleed. We normally quote that about 1% of people who have the operation will need to go back to theatre for bleeding. Coblation is a newer technique for doing tonsillectomies, and that is associated with a lower bleeding rate. So the bleeding rate in coblation, I think, is somewhere in the region of 1 to 2%, but not everywhere has the facilities to do coblation, and not everyone is trained in doing coblation. But I think that is something that we'll see more and more and more of over the next coming months and years. So if you have a child who's actively bleeding from a post-tonsillectomy bleed, you want to involve your registrar immediately, and probably anaesthetics as well. The important thing is to stay calm, even though it looks like a bloodbath. If they're with their parents, they'll be really worried. Even adults are really, really anxious when they're having a post-tonsillectomy bleed. So it's important to keep as calm as possible. If they're in a bay in the hospital, try and cool the patient down as much as you can. Some people say, putting an ice pack on the back of their neck like you would for a nosebleed, that kind of thing. Make sure you sit them up. Make sure they're not lying back and choking. Encourage them to spit the blood out, and make sure they've got IV access. And you've done all the basic ABC management. Essentially, if the bleeding doesn't settle, they'll need to go to theatre for us to stop the bleed in theatre. And in the meantime, it's a case of making sure that they've got a group and save, cross match, giving IV tranexamic acid. We often do, there's also the option of putting some topical adrenaline on some gauze and placing that with pressure in the tonsil fossa. I haven't met a child that will let me do that yet, so it's not particularly well tolerated. And again, just in terms of the gathering information, is really important, really useful to know if they have any allergies, because you'll be asked when the child last ate and the child's weight, so that you can calculate drugs and things like that. If they're not actively bleeding, or they've had a bleed, and the mum and dad now say, this was about an hour ago, they haven't bled since, I'm sure they're fine. It's really important that they're admitted for 24 hours of observation. And the theory behind that is that a small bleed can be a herald bleed. So it can be a sign that there's a bigger bleed to come. And so we always advocate admitting them for observation. So if they were to have a bigger bleed, they would be in the right place. If they're not actively bleeding, or they're bleeding very, very, very slowly, then it is useful to have a look in their oropharynx to see if you can see which side they're bleeding from. Is it the superior or posterior, superior or inferior pole? Is there a clot there? Just gives us a bit more information. If they can gargle, we would recommend giving them some hydrogen peroxide diluted in water and getting them to gargle that around and spit it out to help with the bleeding. As I say, it's quite an acquired skill, and lots of little ones won't be able to do that. I would keep them all nil by mouth until they're seen by a registrar, and we start empirical antibiotics in all of them, essentially. So that's usually intravenous comoxiclav, unless they're allergic. So those are the main things I wanted to talk to you about. I'm just going to touch very quickly on mastoiditis and periorbital cellulitis, as I said. So mastoiditis, again, is something that we do see in ENT, but given how common acute otitis media is, it's a fairly rare complication. So in the history, you'll find that they will have had a recent coryzal illness with one-sided acute otitis media as a result. They're usually systemically unwell, they're irritable, they're not themselves, they're off their food, they've got a temperature. And when you look in their ear, there's often signs of acute otitis media. Now, you may find that there's discharge in the ear from a perforation, but there's usually not. And actually, the pressure from the middle ear, the pus and the infection in the middle ear has kind of spread back and out the way rather than perforating out into the canal. So you'll more often find a bulging red eardrum in these kids than you would discharge, but still you may see discharge in the canal. And all of the signs of mastoiditis, as I'm sure you've been taught before: tenderness behind the pinna, it's red, it's hot. It may or may not be fluctuant. If it is fluctuant, there's already signs of a collection there. And the ear will be pushed forwards and downwards. So how are you going to manage these kids? Anyone that you suspect has mastoiditis needs admission. And if they are scoring for the sepsis 6 or your sepsis protocol in the hospital, treat them as per that protocol. So ensure you've taken bloods, including blood cultures, you started fluids, you've given them IV antibiotics according to your microguide guidance. If there is ear discharge, it's definitely worth swabbing that. And I tend to, particularly for the little ones, involve the paediatric team, partly because they are far more experienced in dealing with unwell kids, and they can help with fluid resuscitation. And it's really important to rule out intracranial involvement. So as good a neurological examination as you can do in that age group. You'd be checking for the facial nerve anyway, because it's an ear issue, and conscious level, and just in general how well or unwell are they. Okay, so Periorbital cellulitis. So this is another thing that we see in ENT, not uncommonly. The causes of periorbital cellulitis are either direct inoculation of the skin, which can come from trauma, or something like conjunctivitis, or spread from infected nearby paranasal sinuses, which is where we come in ENT. Hematological spread is a much more uncommon cause. The thing that we want to know when we're assessing a child or an adult with periorbital cellulitis is whether it's preseptal or postseptal. Now, as you can see in the diagram on the right, you can see my cursor, the blue outline is the septum of the orbit, and that's essentially a membrane, and that separates the eye into preseptal and postseptal areas. Now, any inflammation or infection in front of that membrane, so anterior to that, we call preseptal cellulitis, which is much more common and much less worrying. And anything behind that membrane is postseptal cellulitis, or otherwise known as orbital cellulitis, which is more concerning. So I just wanted to quickly go through the differences between preseptal cellulitis and postseptal. They will both present with erythema and spreading around the eye. So you won't know whether there's orbital involvement until you delve a bit deeper. In preseptal cellulitis, there are no orbital signs, and the orbital signs I've just listed there on the right. So you need to look for an RAPD, assess their colour vision and vision as much as as best you can. Obviously, a lot of this, these orbital signs will be investigated by the ophthalmology team, who are much better equipped than us to really assess for these. But equally, you may be called to someone in the night when ophthalmology aren't around because the nurses are worried about their eye, and it's really, really useful to know what you're looking for. So looking for chemosis, proptosis, and any painful or restricted eye movements, which just makes you think there could be some inflammation in the orbit, basically. Preseptal cellulitis, they're usually pretty well, other than having a red swollen eye. And in orbital cellulitis, they're often more systemically unwell. And if you're ever suspicious of someone having orbital involvement, they need admission for intravenous antibiotics, and then discussing with a senior. They might need a scan to look for orbital involvement, and in particular an abscess that needs draining. And there's often a multidisciplinary approach to these kids. So they have input from paediatric, ENT, and ophthalmology. Whereas preseptal cellulitis can be managed by ophthalmology as an outpatient without even seeing us at ENT. So they really are two very different kind of clinical entities. In terms of management, as I've said, involve seniors early if you're concerned at all. The risk is to the eye, basically. It's another kind of time critical thing where if there is orbital involvement and there's damage to the optic nerve, then there can be irreversible damage to the eyesight. So really important to involve your seniors early if you're concerned. They'll need an examination of their nose, which is us, which is normally quite, it doesn't have to be particularly thorough. It's a case of looking in the nose. Do we think that there is infection there? Do we think there's been a sinusitis? You can use a paediatric nasendoscope, or sometimes I even will just use a thudicums in the front part of the nose, and it's sometimes fairly obvious that there's, mucus and pus coming from the sinus on one side, and that kind of, fits or doesn't fit with the clinical picture. The eye examination is usually done by ophthalmology, and usually done better by ophthalmology, and a full neurological assessment as well, because as well as orbital complications of sinusitis, there's also intracranial complications, and just kind of looking for those, having a suspicion and ruling those out is really important. You're going to do all the normal things, the observations, bloods, fluids, IV antibiotics, according to your local guidance. And we will add washouts for the nose, some decongestants to try and drain the sinuses, and steroid nasal sprays or drops usually as well. In terms of imaging, that's not 100% straightforward, because if we don't think there's a collection initially, we often like to give 24 hours worth of IV antibiotics to see if they respond, and then do a scan, rather than doing a scan initially without any treatment. And in obviously small children, scans can be difficult because they often require sedation or might even need a GA, in which case we only do a scan if we think we're very likely to take them to theatre, which again changes our kind of threshold. So it's not quite straightforward, that one, and that's probably one, a decision for the registrar or even consultant to make in the little ones. And then, if we find a collection, they usually require drainage, and that's usually external, involving a cut on the outside, just medial to the eye, and usually some endoscopic drainage as well. So yeah. I think that's all I had to talk to you about. I think I'm running kind of to time. If you've got any questions, please pop them on the YouTube part below, and I can certainly answer them. And thank you very much for listening, and apologies for the late start.